and Dr. Sanjeev Jadhav. I am a cardiothoracic surgeon and transplant surgeon at Apollo Hospital, Mumbai. Today we have two eminent speakers here. Dr. Jnanesh Tacker, who is considered as a pioneer lung transplant surgeon of our country. He is working at PSG Hospital in Coimbatore, and he is trained at Philadelphia University and worked at multiple places in United States as a transplant surgeon and faculty transplant surgeon. Another eminent speaker, we have Dr. Hemant Pathare. He is chief transplant surgeon at Jaslok Hospital, Mumbai, and he is trained at St. Vincent Hospital, Mumbai, Sydney, Australia. So the today's topic is surgical approaches and for lung transplant and size mismatch between the donor and recipient. So I have a question for you, sir. What are the different surgical approaches for lung transplant?
Lung transplantation can be done through median sternotomy, through a clamshell incision. Then it can be done through antero-axillary incision. It can be done through an anterior thoracotomy. It can be done through a lateral thoracotomy. So there are different ways you can approach and access the pleural cavity.
So my next question is to Dr. Pathare. Which is the commonest approach which is used for lung transplant?
So commonest for a bilateral sequential lung transplant would be a clamshell incision, and in most of the centers doing clamshell incisions, they would nowadays prefer actually to do a bilateral anterolateral thoracotomies, because sternal sparing is the flavor of the moment right now to decrease the complications.
Great. So what are the advantages and disadvantages of clamshell incision versus other incisions, especially the median sternotomy? Because classically as a cardiothoracic surgeon, we are well versed with median sternotomy, and when we want to go on bypass or using a central ECMOs, in that situation median sternotomy is ideal for this situation. So considering that aspect, how clamshell gives us advantages?
The advantages of clamshell is that it gives you access to both the cavities. So you can access the hilum very easily. You can access the apex. You can access the diaphragm. You can separate out the lung very nicely. You can do a good anastomosis. It gives you a good exposure of the hilum. This is the greatest advantage. Also, if you need to do cardiopulmonary bypass, institute cardiopulmonary bypass, you have the pericardium right in front of you. So you can open up the pericardium, aorta, and
so
right
atrium.
There are
advantages of sternotomy are still there, accessing the heart.
All the advantages of sternotomy are there.
Great. So considering that access to hilum, as you don't get in median sternotomy, if suppose the pulmonary artery is short in this clamshell incision, how advantageous this clamshell incision is to access that pulmonary artery?
Yeah. See, if the pulmonary artery is short, you won't have space to put the clamp to do the anastomosis. So the advantage in clamshell is that you can open the pericardium. You can first go on cardiopulmonary bypass, but before you go on cardiopulmonary bypass, because I like to do all lung transplantation, especially bilateral sequential, on beating heart. So you can, if the clamp, then first thing what I will do is I'll try to use a Bahensen's clamp, which is a narrow clamp and it's curved, which you use for aortic valve, aortic aneurysms. If that is also not, you can't put that, then what I would do is open the pericardium, loop the pulmonary artery, right and left, depending on the side, and then snug it. So then you have lots of space to do the anastomosis.
Very true. So what are the other, what is the posterolateral thoracotomy used for?
So actually, as cardiovascular surgeons and thoracic surgeons, most of us did our first lungs through a posterolateral approach. It's the standard operating procedure.
Correct. Yeah.
And if one is attempting to do a single lung transplants, which are still done actually for any non-infective condition, so you can't do it for cystic fibrosis or bronchiectasis. You can do it for ILDs, pulmonary fibrosis, for example. Commonest being the right single lung. So you know the anatomy very well. And if you have to go on bypass for some hemodynamic instability, the pericardium is in front of you. You can just cannulate straight forward. So we know the anatomy. Similarly, if you do a left single, the same technique works too. You can cannulate the descending thoracic aorta, and the pulmonary artery is just open the pericardium, cannulate the main pulmonary artery. So you're on a safe bypass. In fact, priorly, bilateral sequential lung transplants used to be done from a posterolateral thoracotomy. You do one side, the right side first, you close it, change the position, re-scrub the patient, and do the left side. So the anatomy wise, if you're doing it that way, it's much better.
The disadvantage of that method is that if there is bleeding on the other side,
Yes.
and if you are using cardiopulmonary bypass, it continues to ooze, so closing the chest and all that.
Correct.
So that's why we shifted to clamshell.
So as I said, for single lung, you may still attempt
Still,
it.
single lung we can still do it through posterolateral.
Posterolateral thoracotomy.
I agree.
Sternal sparing bilateral anterior thoracotomy, how good is that compared to clamshell or?
See, the anterior thoracotomy, sternal sparing, will on the left side not give you access to the hilum. Therefore, we devised that operation.
Correct.
Dr. Toyoda from who was my mentor.
Yeah.
We devised that operation which we shifted the incision from anterior to antero-axillary. So anterolateral was also not providing access on the left side. So antero-axillary means the incision begins in the mid-clavicular line and goes up to mid-axillary line. So that gives you access to the hilum. It gives you access to both the sides.
Great. So, and what is minimal invasive lung transplantation? Is it the same or it is little different than?
Yeah. In published literature, when we publish this antero-axillary, it is a minimally invasive because you are not using cardiopulmonary bypass, and the incision is only about 7 inches long. And you have adequate exposure, you can do the whole surgery, dissect out the whole lung from the chest wall, and do all the anastomosis very nicely in antero-axillary. That is called the minimally invasive lung transplant.
In fact, if I may say, the trick is to use the longer instruments, which are the minimally invasive instruments.
The strange thing is that we don't need to use any special instruments.
Because we used to do this with minimally invasive things.
Yeah. Suppose if you want to go on bypass in any inadvertent situation, how easy or difficult is to go on bypass with this anterolateral?
Yeah, see, if you are on the right side and you are doing a right antero-axillary approach, you open the pericardium, the aorta is right there, and the right atrium is also there. So right side is not a problem at all. The problem may come at the left side. So you have to open the pericardium again, and like Dr. Pathare said, you have to cannulate the pulmonary artery for venous drainage and aorta for
Descending thoracic aorta.
descending thoracic aorta.
Now we'll come to a discussion of size matching of donor and recipient chest cavity, donor lungs and the recipient chest cavity. So how important is this size matching in lung transplant? Because when we do heart, the dilated cardiomyopathy and ischemic cardiomyopathy, the size is more in the chest. So even a small 50 kg, you can put a larger size heart in that. But is it true with the lung also, or it is little different from the lung?
Yeah. See, for lung, it is my belief that the most important technical point that is there is proper size matching. It's one of the most crucial parts of the operation, because if the lung is too large, first of all, you won't see the hilum properly, the bronchial stump. If you cannot see, your bronchial anastomosis will not be perfect. And if the bronchial anastomosis is a problem, you are endangering the life of the patient. So very important, size matching is one of the most important technical aspects, the most challenging in my belief for lung transplantation.
So how you assess for size matching? Is there any criteria pertaining to chest X-ray, CT scan, or it is just a general experience of doing so many things so many years that you match donor and recipient's chest cavity?
Yeah. There are several methods by which you can try to assess and match the donors. One of them is to see if looking at the chest X-ray, you measure the size from the apex to the diaphragm, and from inside margin of the right lung to the left lung at the level of the diaphragm or at the level of the lowest rib. That is one method. The other is you can measure by circumference. When you measure the donor and you keep the recipient, you can try to measure that. you can measure the length of the sternum. There are various methods, but obviously there will be margins.
As the medical science is all about experience, still the eyeballing
Eyeballing is
donor
the
and
most important, I
Most
think.
important.
Yes, I agree with that.
So,
Even
is
in
there
fact,
any-
if you recently in 2019, there is a review article on size matching.
Correct.
It is in this current year. And if you go through that article carefully, you will find that they have not given any definitive method.
Correct.
So finally, after reading all that, I came to the conclusion that the best thing is based on your eyeballing.
Eyeballing.
You have to project looking at the portable X-ray and comparing the X-ray.
Correct.
So what I do is I take the PA view and the lateral view of the recipient and the portable X-ray of the donor and try to write
Is
brain
there
activity.
any formulas regarding, I understand you said there are some formulas.
There are two formulas for calculating the total lung capacity. Total lung capacity is calculated by the European formula. You can put it up if you want.
It's going on.
Yeah. So that with this formula, which is based on sex and height of the patient, you can calculate the
Correct.
total lung capacity. And there is another formula from Cleveland Clinic,
Cleveland Clinic.
which is based on also age of the patient.
And
With this formula,
sex of the patient.
yeah, up to 2 to 4 liters is the you can
Do away.
disparity you can
Disparities, okay.
try
So-
to compensate. Yeah.
Correct. So, what are the indicators that we should accept disparity, percentage wise or liters of total lung capacity wise? How much we can go ahead, it's okay that.
So
this-
for double lung transplant, up to 2 to 4 liters disparity is there for total lung capacity you
Okay.
can expect. If you are doing a single lung, then 30% increase in size can be accommodated in the chest cavity.
Okay.
Very important to know that pulmonary fibrosis, everything is small. In COPD, everything. So for me, when I choose a lung donor, the perfect donor would be about 4 inches shorter than the height of the recipient.
Great. And suppose on table you find that there is a disparity between the donor and recipient. What are the surgical strategies to deal with such kind of a disparity?
Yeah, so what I do is, now suppose I have taken out the lung. I have a sterile and I'm not sure whether the size is, because the patient was sick. So I take a sterile endotracheal tube, put a sterile umbo bag, inflate the lung and keep it in the chest cavity. If I find that the lung is too big, that only the lobe only can be fitted in, then I deflate it and trim the lung either anatomically or non-anatomically.
Anatomically means by lobectomy or
By
segmentectomy.
lobectomy, yes. Or remove the middle lobe or in the right side, or remove the lower lobe in this thing, or do a non-anatomical transection,
So,
which is called as graft volume reduction,
Graft
or
volume
tailor the lung to the chest cavity.
Chest cavity. So, it
So
is
that you could come to know, you can see the bronchial stump very well. That's very important.
correct. So, that's great. So, is it easier to remove middle lobes or lower lobes bilaterally in that case?
If you are doing a non-anatomical, then you can remove the middle lobe if the fissure is well developed. Just put a staple and fire it. You will have the whole lobe out. It does not increase the warm ischemia time.
Correct.
Warm ischemia time will lead to more warm
Lot of other
ischemia will
issues.
lead to primary graft dysfunction.
Great. So, that comes to our end of discussion. Thank you, Dr. Jnanesh Tacker. Thank you, Dr. Pathare. It was nice talking to you. Great. Thank you.
Thank you.